External beam versus cyberknife?
Yeah, that's a good question. At this point, I personally think the data does not support 8 or 9 weeks of external beam. So in that type of comparison, what I would compare, I would say, let's compare the CyberKnife as the main source of treatment versus external beam and seeds. We call that external beam for maybe 4 or 5 weeks, and then it's called a brachytherapy boost. So if you're making that comparison, I think they both are becoming kind of equivalent. The CyberKnife is a very up-and-coming type of treatment, as you folks know, if you're treating the prostate entirely with CyberKnife, that treatment takes 5 days. It offers 7 units or gray of radioactivity for 5 days, achieving a total dose of maybe 30 to 40 gray. That's a whopping dose of radiation. That's probably higher than can be achieved in any other way. And it turns out that the side effects are actually quite well controlled. So at this point, I'm often asked when a person is choosing his primary treatment, and let's say he's not going to have surgery, he's going to choose radiation. I think you'd be best advised to have a consultation with somebody who does the 5-day CyberKnife treatment and somebody like Dr. Yulo, who would give external beam and seeds, because they're rather comparable, and I think they're both better than the long-term 8 to 9 weeks of external beam radiation. One of the really fascinating areas of management of prostate cancer takes advantage of some of the newer developments. So let me describe a situation. Let's say a person has had primary treatment. They've had surgery or radiation. And now the PSA, after maybe 2 or 3 years, is rising, particularly if it's rising fast. Fast means faster than doubling every 6 months, even every 9 months. So, obviously, as I was talking about in the beginning, the question is, where is the PSA coming from? The first thing that you do, as I mentioned before, you get an off-human scan. Now, one of the possibilities of the off-human scan is that you find that there might be only several places where the recurrence is. If there are 3 or 2 or 1 that show up a sensitive scan, like the off-human scan, that's called oligometastatic prostate cancer. And there's much being written about that. That puts a person into the possibility of having the CyberKnife treat those 3 spots as a primary treatment. And there's a lot of research going on about that. And that's something that is coming on board and much study being done. That is to say, the focal treatment with CyberKnife of 1, 2, or 3 abnormalities that show up on the off-human scan. There's a lot being written about these days. The big question there is, okay, you've got 2 spots, let's say a lymph node and something in the bone. So you're a candidate for the CyberKnife treatment. It's called metastases-directed therapy. You're directing treatment towards metastatic sites. The question is, should you use Lupron and Firmagon at the same time? or just treat them and see what happens. From my point of view, there's a lot to be argued in favor of not using the hormone suppression. Because after all, one of the main gains of treating 1 or 2 spots with the CyberKnife is that you might for 2 or 3 years before there's need for additional therapy. And during that time, you have avoided the side effects of hormone suppression for a period of time. And anybody who's taken Lupron or Firmagon knows that side effects are not insignificant when you take testosterone-lowering drugs. I would imagine some people in the room are on Lupron or Firmagon at this point. Am I correct in that?
Okay, we have another question about testosterone here.
Dr. Weber, I talked to you about a year ago. I've not been diagnosed with cancer. I was on a misdiagnosis where they took me off a testosterone supplement, which I've been on for 20 years prior. My testosterone dropped to 62. Seen another urologist as I was cancer-free, put back on it. In a year now, I'm up to 400. My life is back to normal, except in one area. I lost a lot of muscle mass and strength. What can I do to speed up recovery of that? Is there anything you can help me with there?
Now, you have not been diagnosed with prostate cancer.
Correct.
So you are like so many men who have not been diagnosed, and that's a good place to start. So I would imagine that you have had your testosterone measured. Do you know what the testosterone level is?
Oh, yes. A year ago it was 412.
412. That's actually not that low.
No, but it came off of being 62 the month before. And during that 3 months that I was off testosterone, 3 or 4 months, is when I went through everything these men in this group talk about with Lupron, of the heat flashes, the mood changes, the night sweats, everything like that. So I'm recovering now, but it seems to be the strength that's taken a long time if it ever's going to come back.
Do I understand that at one point your testosterone was 62?
Yes.
Yeah, just for the group, the average man's testosterone is in the range of sort of 400 to 800 milliliters per dl, milligrams per dl, nanograms per dl. So people are called, the word is hypogonadal. That means you have a low testosterone. When the testosterone is lower than about 200, 225. If a person is having symptoms, which could be muscle loss, it could be hot flashes, it could be fatigue, these are all symptoms of low testosterone. If a person is having symptoms and his testosterone is, say, 10, he is clearly a candidate for testosterone replacement, usually with a patch. The goal there is to get testosterone up into the mid-normal range, which would be bringing it up around 400 or 500. And that has not been found to promote prostate cancer, and so it's considered a very appropriate thing to do. Now, if a man is suppressed, now we're talking about a man who might have prostate cancer, and if he's been taking Lupron, and now his testosterone might be 20 or 30, anything less than 50 is considered an effective treatment with Lupron or Firmagon. But his testosterone has been driven down to, let's say, 20. He is clearly going to have side effects. And one of the side effects that he will have a loss of bone density, in addition to being fatigued. In that instance, replacement estrogen is a very important component of the building up of the bone. Because when you lower the testosterone, the estrogen in our body is actually made from testosterone. There's an enzyme that changes estrogen into testosterone. So if your testosterone is really low, then you're not going to have enough estrogen. And so in the case of a low estrogen, rather a low testosterone, you can alleviate some of the side effects, particularly on bone, by adding an estrogen patch. So in your situation, if you're taking a testosterone replacement patch every day or third day, and let's say I think you said your testosterone got back up to 400 or so?
Yes, that's correct.
And that would be a perfectly good result. Now, if you still are having troubles with low bone density, that's when you might add an estrogen patch to it.
Okay, thank you very much.
For that, you probably your urologist may be the guy to talk about that. But the person who might really know about that would be an endocrinologist.
Okay. There's always been a question in my mind of why a person would be put on Lupron or an equivalent just prior to the primary treatment being accomplished. What is the advantage of doing that?
Yeah, that's a big question. I wrote a whole commentary about that. It has been found not to be useful in the long run to use Lupron before surgery. There are lots of studies that give Lupron for 6 months or 3 months. The pathologist would say, wow, I don't see much cancer in your prostate gland, but it doesn't have a long-term effect. So, although I've actually seen some recent articles about using it, but in general, do not precede the surgery with Lupron. That's not the case with radiation. It is customary to give Lupron for about 2 months before radiation. And the reason for that is fascinating. I wrote this whole commentary on this issue, was that having a low testosterone makes the radiation therapy more effective. So in a sense, dropping the testosterone potentiates the effect of radiation therapy. And that's the primary reason for preceding radiation therapy with Lupron.
Okay, thank you. So in other words, it increases the efficiency or the effectiveness of the radiation treatment?
Yes, that's exactly right.
Okay. Anybody else?
Yeah, some tests that might help the guy who is watching his PSA rise and he's discussing with his doctor, when should I do a biopsy? There's some testing involved that helps the decision-making of the doctor-patient
Can you hear me okay, Dr. Weber? Can you hear me okay?
I didn't get that, and I want
Okay,
to
no
make sure I
problem.
get that question
I'll repeat
clearly.
it. We have now some patients that we have convinced they should watch their PSA. The PSA starts to rise. Now the conversation with the doctor, his doctor, is when should I do a biopsy? We have some testing that has come on recently that helps make that decision. Is that true? And can you talk about them?
Yeah, that's a really tough question. If you're trying to make that decision, basically on the PSA alone, lots of the studies in Europe would suggest that, this may surprise you, if the PSA rises to above 3, that's an appropriate situation for a biopsy. That surprises a lot of people, but that's the practice in Europe. There are a couple tests which are available that help to determine when a PSA is, say, 4 or 3.5. There are some people in whom, of course, they don't have prostate cancer. That's the trouble with the PSA test. It doesn't necessarily reflect the presence of cancer. It can, but you don't know. And there are a couple tests that would try to help make that decision. And one of the tests that is easily available is called the percent free versus total PSA. That's, every lab does that, percent free versus total. And if a person has that ratio and it's better than 25%, I mean, you probably don't have prostate cancer. If the ratio is 15 or 10%, that's a worry, and you'd want to have a biopsy in that situation. There are two blood tests that are much written about but rarely used. I don't want to spend too much time talking about them, but the names are the Prostate Health Index. That is a test that tries to detect aggressive prostate cancer as opposed to less aggressive. And the other one is called the 4K. But I suspect most urologists don't do those tests. But the percent free is often done, and it can be a guideline.
Thank you. Pass you along to another man here.
Do you believe chronic BHP, like over several years, can be a precursor to PC? Or prostatitis, or BHP? I think they're both the same. Chronic, like over several months, be a precursor with a high majority of males to PC when they get older.
Now, we're not talking about BPH, but we're talking about prostatitis.
Yeah, which is a large prostate. When we're older, like over 66, can it be a precursor and a higher percentage of males to lead to prostate cancer?
Yeah, I don't think that BPH is a prelude to cancer. If you have a biopsy, if you have what's called high-grade PIN, that's prostatic intraepithelial neoplasia, that's a precursor. But you'd have to have a biopsy in order to determine that. It's a huge bit of research being done on the role of inflammation as it might pertain to getting prostate cancer. We know that inflammation of the prostate will raise the PSA. And that's why so many urologists, when a person has had, let's say they've had a PSA of 2 or 3 on a regular basis, and then the next time the PSA has gone to 5, and they look at that and say, wow, and then that's concern. The concern there is whether that is a temporary elevation because of prostatic inflammation, like prostatitis. Usually they will give a period of antibiotics to just check that. But the role of inflammation as causing prostate cancer is very much under consideration because inflammation can increase cell growth. It can promote cells coming to the inflamed area. But for the most part, inflammation is of concern because of temporal prostatitis. And that usually leads to a period of antibiotics to see if the PSA goes down.
Okay, let's pay the advertising portion of the event now. Once again, your email address, you offered your services. Could you repeat your email address and tell us more about the good work you do on a monthly basis on the Prostapedia, I think it is. Would you please go ahead?
The leader of your group is
Bob Freeborn.
Pardon?
Bob Freeborn.
Oh, okay. Well, look, I will send Bob Freeborn my email address, and anybody who wants to be put on the list to get the commentary, just give me an email, and I will send it to the lady who sends out this to 400 people in this area. And so if you send me a request, I will have your email, and I'll give that to the young lady who does the work, and I will put it on the list.
And along with that request for your publication, we might be able to ask a personal question as well.
I'd be happy to interact with anybody about a personal question if they wanted to email me. I do it all the time. It's a pleasure.
Okay. Any other questions? Now's your chance.
Yeah.
Okay.
Okay, so I had my prostate removed. Why do I still need to get my PSA checked for prostate cancer?
Say that again?
I had my prostate removed. Why do I still need to get my PSA checked for prostate cancer if my prostate is gone?
Yeah, well, that's a good question. And you are having that done because even though you've had a prostatectomy, you are not assured that there might not have been some cells that are either remaining where the surgery was done or having escaped elsewhere. And so you're being checked probably every 6 months to monitor to see if there's anything remaining in your system that is cancerous. So it's terribly important to have follow-up. If you don't have follow-up, you could be a couple, 5 or 6 years down the line, you'd be surprised that something was actually building up steam that you just didn't know about. So following up primary radiation and primary surgery, you need to have periodic monitoring, I would say every 6 months for a while, of your PSA.
Okay. Anything else?
Well, it's a pleasure to talk with you. I'm happy to talk anytime, and Bob, I'll send you the. There's another place that has a lot of good information. There's a website that I participate in, and I will send that also to Bob. It's called prostatecancerfree.com. It has all of my articles archived there and a lot of other information about prostate cancer. So I'll send Bob both.
Okay, that'd be great. Thank you.
Okay.
Well, thank you very much. Thank you very much, Dr. Weber. We enjoyed talking with you again, and we look forward to having you back again sometime.
I'm willing to do it anytime.
Okay, thank you. Have a good evening.
Bye-bye.